Welcome back to Plum Peeps, everyone. It's great to be back with Furf doing one of our favorite kind of episodes, which is the Plum Peeps Fellows Case Files. And today we are joining the University of Virginia. Furf, how are you doing today?
Good, doing well. After the post ATS glow, I'm ready to get back to our standard podcast. Very excited for our case files and to be virtually visiting Virginia. Our guests are all joining us together, which is like, I love that. It's like good camaraderie as we discuss this case. So excited to dive in.
I know. I feel like it's a week later after ATS, but I still feel like I'm on San Francisco time, and I'm still
Yeah.
still trying to get used to being back on the East Coast.
I think I just have permanent jet lag forever now, like just as part of being a medical training or something like that. So we'll see if I recover.
I know. Well, so great to see you virtually today. And so excited to have all three guests joining us in the same screen, which I love to see. And I have the honor of introducing our first guest, who is Dr. Matt Freedman. Matt completed his residency training at Virginia Commonwealth University and is currently a second year fellow at UVA. Welcome to Pull Peeps, Matt.
Well, thanks for the great introduction, Christina. I'm a big fan of the show. It's great to see you all again, and we're happy to be here.
Yeah, thanks so much. Yeah, I guess I should mention that you guys came up to us actually at our live episode at Chest asking if we could do a case files. Of course, we're always excited to, but it's so fun that we got to like meet people in person. So I'm glad we finally got this together. And on that note, we have another guest to welcome. Next, we have Dr. John Popovich. John completed his residency training and chief year at UVA and stayed there for his pulmonary and critical care fellowship. Thanks for coming on the show today, John.
Thanks so much. I'm super excited to be here.
Yeah, so great to have you both. And our third guest today, excited to introduce Dr. Tim Scialla. Tim is Associate Professor of Medicine at UVA, where he's also the Program Director of the Pulmonary and Critical Care Medicine Fellowship. So great to have you back, Tim. Dave, and I all did our residency training here at Hopkins, and he and Furf are bonded for life as they both were Assistant Chiefs of Services, our chief residents. And Tim also did his fellowship training here at Hopkins. So I think we have some bonds that will never be broken, but excited to have you back on the show, Tim, and excited to highlight your great fellowship training program.
Well, thanks so much, Christina and Dave. We really appreciate being here. Looking forward to this. Should be fun.
Definitely. Before we dive in, just our standard disclaimer. As a reminder, this podcast is not meant for specific medical advice. The views we express today may not necessarily reflect those of our respective employers. And the case we present today will be HIPAA compliant. We won't mention any names or identifying details, and some details may have been changed to protect the privacy of our patient.
Awesome. Thanks so much, Furf. And I'm so excited to dive in. So we'll go ahead and start with you, Matt. Can you tell us a little bit about the patient that you met and how the patient initially presented?
Absolutely happy to get us started. So, for this case, we'll be discussing a 52-year-old male. His past medical history was notable for psoriasis as well as HIV/AIDS, with a most recent CD4 count of 71 and on heart. He came to the ED after multiple days of fatigue, shortness of breath, a non-productive cough, subjective fevers, and some watery stools. He further went on to let us know that he had 10 pounds of weight loss over the last month and denied any other symptoms, including hemoptysis, night sweats, or any other respiratory symptoms. The shortness of breath had been progressively worsening over the 3 days, and now he could barely walk 10 feet without feeling winded. Other notable things are his home medications. He's on Biktarvy as well as Prescovix and Bactrim prophylaxis for his HIV. He reported compliance with all of these therapies, but did note that he had some recent regimen changes due to some resistance patterns noted recently with his infectious disease doctors. His social history was fairly unrevealing. He did not smoke, drink, use other drugs, or had any recent travel of note. His family history was also pretty non-contributory. On physical exam, he had a temperature noted at 103 degrees Fahrenheit, heart rate of 110, a blood pressure of 110 over 80, and he was known to be saturating between 90 and 92% on 6 liters of nasal cannula oxygen. Furthermore, on physical exam, he appeared ill and tired. His mucous membranes were dry. His cardiac exam showed tachycardia, but with a regular rhythm and no murmurs. And most notably, his pulmonary exam showed increased rate, effort, and diffuse crackles throughout all lung fields, accompanied by a harsh cough.
Thanks so much, Matt, for walking us through that, and some great kind of objective as well as subjective data, and really appreciate you, including some abnormalities in the physical exam, right? Because when you're talking about this patient, it seems like some acute versus acute on chronic, presentation that you mentioned. But certainly would describe him as being sick, right? I think a lot of times we work with trainees and we're like, is this patient sick or not sick? I would be concerned about this patient and trajectory. But Matt, you mentioned, some things to make sure that we take note of, including pulmonary symptoms, the diffuse crackles on exam, and he is hypoxemic, so his lung pathology is clearly one of our primary concerns. And Furf and I have done several episodes in the past, a couple of other fantastic case files where we've talked about the differential in someone who is immunocompromised, presenting with pulmonary symptoms, and we've highlighted the approach of thinking about their immunosuppression to really help guide our differential and diagnostic process. For example, so we talked about in the past, someone with a primary B cell deficit usually will have a certain list of susceptibilities that we should be aware of, as well as a patient who's neutropenic. There may be some overlap, but there'll probably be some distinct differences between the two. And we'll make sure that we post some of these infographics for you to remind yourself about. And given this patient, we know that he has AIDS, given his HIV diagnosis, and a CD4 count is 71. So while his immunodeficiency is primarily T cell mediated, he almost certainly has impaired humoral immunity as well. So trying to put this patient together and think about the diagnostics as well as the differential. Dave, how would you start your diagnostic reasoning approach for this specific patient?
Yeah, thanks, Christina. As mentioned, I always like to think about the host, right, and how that's going to influence the differential. For this patient, he has HIV, he has AIDS, based on his CD4 count, and so that's impacting how I'm going to think about his pulmonary presentation. So I think the first thing that usually comes to mind with somebody who has AIDS and a CD4 count of that level and pulmonary symptoms is PCP pneumonia. This is just one of the common diagnoses that we see in the AIDS population. It's important to note that still bacterial pneumonia and strep pneumo are the most common causes of pneumonia in a patient who has HIV/AIDS, just because common things being common. One thing that's interesting, though, is actually there's a bunch of studies that show that if you're on antiretroviral therapy, even if you have a low CD4 count, it actually decreases your chances of bacterial pneumonia. So the fact that he has been taking therapy, even though that he has this suppressed CD4, lowers that a little bit. Still, obviously, something that we're going to have to rule out. And so we'll think about all common causes of CAP. But I definitely want to think about PCP in this patient. He has a low CD4 count, and then he is on prophylaxis. But it's important to remember, one, prophylaxis isn't always perfect. One, it only has a certain amount of efficacy. Two, sometimes people aren't always taking it as directed. We don't know that for this patient, and so we shouldn't assume, but we would want to ask him about it. And finally, there are different levels of prophylaxis. So he's on double strength Bactrim 3 times a week, which is a totally standard acceptable regimen. But people can be on anything from single strength 3 times a week up to double strength every day of the week. And the different regimen that you're on may impact the likelihood that you're going to get this diagnosis. I'll also say that his presentation is pretty reasonable for an HIV/AIDS patient who comes in with PCP pneumonia. For someone who doesn't have AIDS and comes with PCP, it's often more indolent. They sort of have this progressive worsening of chronic shortness of breath, whereas in an AIDS patient, they really come in sick, fevers, cough, and in a more acute presentation. So definitely high up on my list. Other things that we're going to think about, we're thinking about some atypical organisms that can cause pneumonia, mycoplasma. We certainly want to think about tuberculosis in anyone who has AIDS, especially if they're from an area where it's an endemic and a high population or high rates of that. Endemic fungi certainly are at risk when you're immunosuppressed to the degree he is. Histoplasmosis, coccidiomycosis, crypto. CMV, you can have sort of diffuse CMV if he has other symptoms. A little bit hard to detect and know what to do with the CMV viral level in a patient like this because it often can be reactivated. But these are all things I'm thinking about. One other pearl I remember from our old Polk time on the Polk service at Johns Hopkins, seeing HIV/AIDS patients, is that actually Legionella is pretty uncommon in these patients. And so even though they get almost every other infection a lot more, this one is a little bit less common. And then finally, while infection is number 1, 2, and 3, we have to think about some other things that can cause this. So you can get inflammatory pneumonias, just like anybody else could, organized pneumonia. AIDS patients are certainly more likely to have lung malignancies. They could have Kaposi sarcomas in the lungs. So there are definitely things that we have to think about. And then finally, it sounds like his regimen was changed and he based on some resistance. And so you can get an iris type syndrome if all of a sudden he had like a high viral load and low CD4, but now he's on effective antiretroviral therapy. So maybe a little lower on the differential, but just some things I'm keeping in mind. So with that large differential, we'll obviously have a lot of ongoing tests that we're going to want to send. John, maybe you can talk us through what the thinking was at the time and what tests this patient got for the next steps of the workup.
Yeah, I think I have some more data for you. When he arrived, he had a white count of about 3.3, which was not all that different from his priors. His CMP was entirely unremarkable with no red numbers in REMR. We drew an arterial blood gas when we met him, and that had a pH of 7.46 with a PCO2 of 41 and a PO2 of 70. That was drawn on 6 liters of medium flow nasal cannula. So we calculated a P to F ratio just a little bit north of 150 for him at that point. And then we sat down together as a team and kind of thought about what other non-invasive studies we should send for a guy like this. And, one of the things that I try to preach when I'm talking and teaching our residents is when you meet someone like this who has a really broad differential diagnosis, don't neglect usual suspects. Like this person could have a standard pneumonia just like any of us. So we started with what is the workup that we would do for someone with just severe community-acquired pneumonia. And we looked back at the IDSA guidelines, and based on those, we sent based on those, we sent sputum cultures, we sent blood cultures, we sent a urine strep and Legionella, and we sent flu, COVID, and RSV swabs. All those were pending as we were admitting him. And then we stepped back and thought about what would we add on, what would we broaden to for someone with a diagnosis of AIDS. He mostly has a T-cell defect. So for him, we were thinking about invasive fungal pneumonias. Like Dave mentioned, PJP was up there. We thought a little bit about aspergillus, and then we thought about the endemic mycoses. In Virginia, that's usually mostly histo and blasto. We don't have a ton of cocci around here. To get at those, we sent an LDH. We sent a serum 1,3-beta-D-glucan, which is called a Fungitel in our system. I think is the proprietary name for that. And then we sent a galactomannan as well, which is an aspergillus antigen. And then finally, urine histo and blasto.
Thanks so much, John, for walking us through that. And I think, again, some important points that you talked up, and probably I know the scope of today is not to talk about necessarily triaging, but when we're, hearing this information, right, he's on 6 liters nasal cannula with the P to F ratio, as you mentioned, a little north of 150, right? But is this someone who, where are they going to be triaged and kind of going through that thought process, to the floor, to an intermediate care unit, or to an ICU? And I'm sure this is going to be institution specific on whether it's floor versus ICU and whether an IMC is available or not. But given this, I'm concerned about, I remain concerned that this patient's sick and concerned about trajectory for him. And I'm sure the case will evolve and we'll hear more about that. But I really like the differential that you described so far and all of the non-invasive testing that you ordered. And as you said, right, when you have a patient like this, there are so many tests that you can order. So really being thoughtful as a team and talking about what makes the most sense based on the host as well as the geographic region. As you mentioned, things are going to be more common in Charlottesville versus not. So thanks for walking us through that helpful guide. I wanted to just specifically, say too, I spend a lot of my time in our oncology ICU, so I feel like serum fungal markers are something that's commonly sent on any admission that I have. So, but I think 2 labs that are worth pointing out in this time, and specifically the role of LDH or lactate dehydrogenase, as well as the serum beta-D-glucan for patients. And I think elevated LDH is nonspecific, but can be commonly seen in patients with PCP. And this is really due to the alveolar epithelial damage as well as associated inflammation. So normal LDH has a high negative predictive value, particularly in HIV-associated PCP. And there's one meta-analysis that we'll put on our show notes for you that where a normal LDH had a negative predictive value of greater than 90% for ruling out PCP. So while not used in isolation to rule in PCP, it can be a helpful test in excluding the diagnosis when the clinical suspicion is low to moderate. And I think the other test that's worth noting is the fungitel, as you mentioned, John, or 1,3 beta D glucan, because this is often elevated in PCP pneumonia because pneumocystis shares this target with other fungal organisms. Sensitivities can be up to about 90 to 95% with a high negative predictive value. So basically, a normal beta D glucan makes PCP much less likely. And I tend to use this specifically in settings where, a BAL may be delayed or contraindicated if someone's on, too much high flow nasal cannula and, doing a bronchoscopy may lead to intubation. And just wanting to point out, though, not specific to PCP, but can also be elevated in other disease states such as candidiasis as well as aspergillosis. So want to just to highlight negative predictive values of testing, how that relates to our pretest probability, and how we're going to determine what tests are going to be used for the patient in front of us. But I'm sure that there were more testing diagnostics that were done, and I'm sure we'll get to labs here shortly. So Matthew, what can you tell us next about the patient's diagnostic test?
Well, Christina, you had a good read of the situation. They did pursue imaging for this patient. They started with a chest x-ray. The chest x-ray was notable for bilateral upper lobe and perihilar consolidations, as well as some reticular opacities. They got a follow-up CT chest without contrast, and that showed, again, bilateral upper lobe ground glass, septal thickening, and was also noted to have peripheral cystic changes. Now, you hear these buzzwords and instantly you get shot to different differentials. And this is where the patient's clinical history and presentation time course really take you in different diagnostic directions. Given their history of fevers, of cough, of the acute presentation, and infectious etiology remained at the top of our differential here. The findings had a pattern that we often can see in a viral pneumonia, like a COVID or a CMV, especially in an immunocompromised patient. PCP pneumonia also remained very high in our differential, especially given their low CD4 count, and even despite being on prophylaxis, like Dave said. Certain fungal infections like aspergillus also could have patterns in this nature as well. The peripheral cystic changes instantly take you to differentials like an LIP or pulmonary Langerhans, but with their presentation, the time course, we really didn't feel like that fit this patient's presentation. And then likewise, the upper lobe predominant ground glass could make you think HP, but with the infectious sounding presentation and acute nature of it, we felt that to be less likely as well.
That's great. And we will post these imaging up with the episode and share so you can take a look and see what you think about the pictures and what differential you would have. I think this is always an interesting time point in a patient's course when they present like this. Two big questions that come up for me is the first question that now I think is super common is about steroids in a patient like this. We have increasing evidence for a lot of our critical care conditions, but about when we're using steroids. Certainly there's increasing evidence in using it for community acquired pneumonia, increasing evidence for using ARDS. If we had really high suspicion for PCP and the patient was this hypoxemic, they would likely get steroids along with their treatment, or they should get steroids along with their treatment. But we don't have our diagnosis yet, and then we always get a little worried about mostly invasive fungal infections and adding steroids. And so I think it comes up with a patient who's sick and getting sicker like this. Should we just pull the trigger? But then we always want some more diagnostics. And then we're in this tough place where we're somewhat limited with our diagnostics when a patient has really bad respiratory distress. So Tim, I was hoping you could talk through this a little bit. It comes up a lot for trainees. Any pulmonologist we talk about is like, you have an immunosuppressed patient, very sick with some pulmonary source. This person ended up intubated, but maybe they're lingering on. Maybe they're on some high amount of oxygen or high flow. People are worried to bronch. And there's an argument there. It's like, should you just intubate, get some diagnostics, or should you try to do non-invasive diagnostics? So just curious if you can share your thoughts.
Yeah, it's a challenging situation, and you have to approach it with a lot of humility in knowing that whatever choice you make might be the wrong one, but you do the best you can. There's this idea, will it take a rotation or a revolution for this to get better? A rotation is 24 hours, the earth around its axis. A revolution is more like the moon going around the earth in 30 days. So what's my turnaround time if even in the perfect setting, if I get this right? And so if you think someone's going to turn around quickly, I think non-invasive, forms of non-invasive ventilation or high flow is the way to go. And we've certainly all had success with that. This patient just gives you the feel that things have gone, they've gone from bad to worse over the last month, and that whatever this is, it's not going to get better anytime soon. And so it just seems like he's going to, like you said, end up intubated. There is one little heuristic I've used on bronchoscopy in the hypoxemic patient. And what I was taught, and I was taught this as a junior faculty when you start as a faculty member and people just kind of ask you to do bronchs, you feel like you should do whatever they tell you to do, that you don't have the experience to ever say no. And so I asked one of the older attendings where I was a junior faculty, how do you approach these hypoxemic patients? And he said that he would put them on a non-rebreather for about 30 minutes and do a blood gas. And if the PaO2 was over 150, he felt like they could tolerate a bronch, probably wouldn't really get intubated, that they had the reserve. If the PaO2 was between 100 and 150, he'd say you got about a 25% chance they'll end up intubated after the bronch. So be ready. And if it was under 100, that person was going to end up probably intubated. And so you probably wouldn't do the bronch to push them over. And I've always used that. There's no that's not a journal or an article, but it's always a kind of a teaching pearl I've used to help people triage how to think about bronchoscopy in high-risk patients. And all those bronchs should be done in an ICU. So that's one thing I would bring up here is I would imagine at this point we're going to have to intubate this person to get the information we need. But getting back to the point of immunocompromised patients, we know that immunocompromised patients who don't get intubated, Captain Obvious, do better than those that do. And we also know that if you linger on non-invasive ventilation or high flow as an immunocompromised patient and not get intubated early, but later you do worse. So it's always that tricky part. And it comes back to being at the bedside. And this is hard to teach trainees, but there is a tacit knowledge and a gestalt that comes with looking at people at the bedside that says, let's give this person another 24 hours and let's intubate now. And I wish I could explain that better than the gestalt, other than to say, if they're really tachypnic and their mental status stinks, we're kind of done.
Yeah, that is such great points. And I totally agree with you. It's so hard walking that line because they do well if they can skate by, but if they can't skate by and it's day 7 of having patient self-induced lung injury, then you've really kind of done a disservice if you're getting intubated at that late time. So yeah, something that just kind of comes with some experience and then I like that. Sometimes I like those knowledge that it's not in a journal article, but that seems like a very practical, probably pretty helpful decision-making tool, and at least like the framework helps you get an idea of what you should do next with these patients.
Yeah, and it also just helps tell patients and their families what to expect with a high-risk bronch with some numbers around it so that they can understand the risks that sometimes our hematology colleagues do not necessarily share with them.
Yeah, I love this discussion. I think from today I'm going to be like, now next time with a fellow, and be like, we have to do the Scialla protocol and like put the non-rebreather on for 30 minutes and then check the ABG, and then they're gonna be like, what are you doing? I was like, no, Tim said it. But I think that it's a great kind of perspective, and you brought up so many great points, Tim, about this, right? Just looking at the patient in front of you, talking with them, really coming up with like a patient-centered approach to things. And like you said, a lot of times in immunosuppressed patients may often do worse before they get better. So I know in this patient worsened to the point where he did need intubation. So I think at this point, right, you're going to have to think about, how much oxygen is he on, how high is the peak, but whether or not to do a bronchoscopy in this setting. And interested to know, I think there'll probably be like institutional variants. I know some faculty will do a bronch immediately after someone's intubated. Others want to let things kind of settle out a bit and then go ahead and proceed. But Matt, I'm assuming that given this patient and given our case today, that probably further diagnostics with a bronchoscopy were in his plans. But so I guess one, if you would tell us, kind of the next steps for the course for this patient, and two, as a fellow trainee, when you're thinking about a patient who is immunosuppressed and you want to do a bronchoscopy with a BAL, what type of studies are you thinking of making sure that you get and don't want to miss when you're going to go ahead and do a procedure on someone?
So, unfortunately, the patient did worsen throughout that first 24 hours and did necessitate intubation regardless of need for procedure. Didn't make our decision easier if we were going to do a bronchoscopy. We didn't get to enact the Scialla protocol. I'm a huge proponent of cost-conscious care and being really judicious and targeted with your testing, but this is not the time for that. And the IDSA guidelines would back that up as well, especially in a decompensating immunocompromised patient where finding out the diagnosis or finding out what the diagnosis isn't has really significant clinical outcomes and can really alter the course for the patient. So this is the time to send a broad workup, because even just from our discussion before, the differential is so vast that you just have to get everything that you're considering and worried about. And so IDSA would suggest that when we do bronchoscopy and we send the BAL, we send it for a cell count, for bacterial cultures, for fungal studies like an aspergillus antigen or a fungal culture, AFB culture, a respiratory pathogen panel, CMV DNA quantification, Legionella. Although now I'm thinking, because of what you said, Dave, maybe I don't have to send that as much, but I'll probably still click the button.
Probably send it, yeah.
Then we consider cytology, PCP, direct fluorescent antibody or DFA, and then the PCP PCR testing as well in our immunocompromised patients. So that's more or less what IDSA would recommend in immunocompromised patient presenting with acute respiratory failure, and that is more or less what we sent for this patient. We actually sent all of that. So
At Hopkins, would they just send the Cheech at this point?
This is the time for the Cheech. This is nothing. This is like half the test that'll be sent off.
And I do want to note, we sent 2 separate tests for PCP because our differential was so high, and not everyone might be familiar with the difference between those testing, or maybe they are. But the difference between those tests, the direct fluorescent antibody, the benefit is it's quick. They're staining the BAL sample and they're looking at it under a microscope, and you can get that result same day. We did get that result same day. It's very specific, but it's not as sensitive. So it's a great initial test and something you should definitely send to anyone you're concerned for PCP, and really in people who are immunocompromised with respiratory failure. Cytology actually accomplishes a similar thing. It's also being examined under a microscope with special stains. At our institution, this turnaround is a little bit slower, but that's another way to get that direct visualization. The PCR is very specific, very sensitive. It's actually even more sensitive than specific, but the turnaround time is slower. You're 2 to 3 days down the line before you get that result back. And in patients like this, 2 to 3 days can be really meaningful. So we chose to send it all, and probably would do so in similar patients in the future. So all that being said, that day, the day of the bronch, later the DFA did come back positive for PCP, and cytology also showed the same soon after. And then the PCR came back positive 2 to 3 days later.
I love that you pointed out that the DFA and the cytology are someone looking under a microscope. We actually had a recent case where a DFA was positive, but it kind of didn't make sense. And then in talking to someone, they were like, actually, we looked at it again and it was negative, and so it's just always helpful to know which of the tests where it's it is requiring a person doing the interpretation. Obviously I don't want people to distrust when they see a positive DFA from PCP. I mean, that should be taken as a positive test, but it's just helpful to know how the tests are run.
And, for this case too, the bronchoscopy gave us our diagnosis, let us pursue the treatments that we're going to discuss going forward. But people have asked this question before in our immunocompromised acute hypoxic respiratory failure patients. Does it change management? Because we've all done bronchs that didn't show anything, and we put the patient at risk for seemingly no reason. So a couple studies have looked at this. There was a 2019 retrospective study that looked at 217 patients to see would a BAL in this clinical scenario change management. And they actually did see that it changed the management 63% of the time, with a bit of a liberal way of how they interpreted changing management. But they also noted that about 15% of those patients experienced a complication, most often hypoxemia or bleeding. So there was a risk to the procedure. They actually looked at this at the same time with a prospective trial in the European Respiratory Journal in 2019 with a similar question. And this one looked at 1,600 immunocompromised patients in the ICU with respiratory failure. And in this one, they found about 40% of the time it led to a change in management, but 11% of the time they had worsening respiratory status. And these patients also had higher ICU length of stays and higher hospital mortalities. So there's consequences, but there was shown benefit, and it's all comes back to that risk benefit analysis we have to do for every patient.
Thank you so much, Matt, for walking us through that. And I couldn't agree with you more, right? I think a dear friend of mine just recently, we were having a conversation, right? She's like, there's so many, things that you could do to a patient, and there's so many things that you can do for a patient. And, what diagnostics are going to be to a patient and for a patient. So I think really understanding, the bronchoscopy that was pursued, what it have changed management in this patient. I think some will argue, if this with this immunosuppressed patient coming in and how sick he was and the amount of hypoxemia, which you just have empirically started PJP treatment on him anyways. So I think lots of different things to discuss. And as Tim said earlier in the case, right, not a right or wrong answer, but you do the best that you can with the information and the patient in front of you. So really appreciate you kind of walking us through those different studies and why the PJP DFAs can be helpful and how they're different from some of the other standard tests that are sent. But so seems like we have our diagnosis now. This immunosuppressed patient coming in with AIDS, hypoxemia, now with confirmation of PJP pneumonia. So I'm John, I wonder if you could help walk us through kind of the next steps as far as management for this patient and any other teaching points that you learned along the way.
Yeah, for sure. As you guys were mentioning the question of steroids earlier, and I often feel like in pulmonary and critical care medicine, we're just like waiting for any excuse to give steroids. Yeah. And I was kind of reflecting on just how much practice has changed even in my 5 years as a trainee. And for context, this patient we met them and took care of them a couple years ago. And we started steroids once we had the diagnosis of PJP pneumonia. Our division and our institution has, I think, in the last year or so, really incorporated the Cape Cod trial into our practice. So I think if this patient came into our ICU today, we would have made a diagnosis of severe CAP in the ED and started 200 milligrams of hydrocort a day. In this patient, however, in a couple years ago, without that data, once we had the diagnosis of PJP on the BAL, we started high-dose IV trimethoprim sulfa or high-dose IV Bactrim. And because he was as hypoxemic as he was, we didn't measure an ABG on room air, didn't think that would be safe for obvious reasons. But presumably he would have had a arterial arterial PO2 less than 70. So he got some prednisone as well. So we felt really good that we had a diagnosis. We felt really good that we had a treatment plan for him. Unfortunately, his case took a bit of a turn as he developed worsening shock. Right after intubation, he was initially on like single digits of norepinephrine, but that progressed pretty quickly to requiring in the double digits of norepinephrine plus some vasopressin plus on and off epinephrine as well.
Yeah, so not uncommon for us, obviously, in the ICU to have somebody who's holding out their blood pressure, they get intubated, and then they're in a sort of severe shock picture. And, this is a patient who has propensity for lots of different things. So even though our mind wants to jump to common things being common on shock, we always have to take a systematic approach. So Tim, I was hoping you could talk us through how you approach a immunocompromised patient who develops a new shock in your ICU.
Yeah, sure, Tim. I will. I have to share a quote, right? Mm-hmm. The classic quotes here. One of my favorite quotes is Dwight Eisenhower, who said that in the context of war, I have often found that plans are useless, but planning is indispensable. And so this is a good situation where our plan was that we would give IV Bactrim and steroids and be the heroes of this. And all of a sudden our plan has been run amok by undifferentiated shock. So I try to keep shock as simple as possible because it's not simple, but my brain needs it to be. So I start off with the dopamine versus Levophed trial, which was a very big trial with a fairly broad eligibility criteria. And so there's like over 1,000 patients, and you get a good prevalence of, shock in America. And if you look at that study in a med-surg unit, 65 to 70% of them had distributive shock, 5% had obstructive shock, and then the rest was a combination of either cardiogenic, hypovolemic, or hemorrhagic shock. And so you're always playing the numbers. And so in the MICU, distributive is always going to be the first one you go to. That said, there is some other things you can do to try to help your pretest probability. Physical exam still underrated in the ICU, so you certainly should go to the bedside, feel the patient, because cool extremities will put you into one of those categories more than others. Capillary refill is also a very helpful thing. Distended neck veins is also a really underutilized OG physical exam finding, in the sense that distended neck veins will certainly make you worried about obstructive or cardiogenic shock more so than the others. And then finally, rounding it out is the use of POCUS, which I think has become essential in the management of undifferentiated shock. And really, we're really trying hard to push that into being a habit forming process that early on in our assessment, that our trainees are getting the ultrasound and looking at cardiac function and the IVC.
Yeah, I love that, Tim. Well, two things that you said resonated with me. One, just a simplistic view of complex physiology. I also tend to need that in order to understand things. So appreciate your relation to that. And then I think this POCUS. I feel like nowadays trainees, both residents as well as fellows, are integrating POCUS as a extension of their physical exam. Right. I think all of us here today, the physical exam is so important, but POCUS can be really useful given its importance in bedside critical care evaluation. And glad to hear that you support that and support your trainees and feeling that they can use that and have that kind of as a different arsenal or agent in their arsenal, I will say. And Matt and John, I'm sure that you spend a lot of time doing POCUS and evaluating really sick patients going into your ICUs. And Matt, I'll probably just start with you first. Interested to hear if you have a preferred approach for assessing shock with POCUS at the bedside, something that you do systematically or you want to share with those listening today.
Yeah, absolutely. And, first I'll say, Tim, that was a great framework to look at shock. And second, I am amazed that we got this far into the podcast and are only now just quoting war generals. It's very impressive. To answer your question, I used to kind of subscribe to various algorithms. There's the abdominal cardiac evaluation or the ACEs assessment, rapid ultrasound shock, the RUSH assessment. There's trauma assessments, FAST assessments, but I kind of found they all are asking the same questions and answering them in very similar ways. And I've molded them all together to the basic tenets of what I'm looking for in my shock assessment with ultrasound. And fortunately, I have my lovely model here, Dr. Popovich, that kind of demonstrate what I do in my quick bedside decompensating patient that needs a shock assessment. I usually start out with a good cardiac exam. It consists of the 4 typical cardiac views. And, this is our typical ICU patient, thin, young male who runs 10 to 15 miles every day. So it's a good proxy. So we do our parasternal long axis, we do parasternal short, apical 4-chamber, subcostal, and then sometimes we'll throw in an IVC assessment as well while we're in that subcostal view to get just a broad idea of a proxy to their volume status, even though there's a lot of data to suggest that they may or may not be reliable. And then in my shock patients, again, combining some of those other algorithms, we'll consider doing lung ultrasonography bilaterally to look for pneumothorax. We will do looking at Morrison's pouch and the splenorenal pouch and the bladder to look for intra-abdominal bleeding or free fluid. And then some would suggest to also scan the aorta to look for aneurysms or rupture as another cause of acute shock. So based on the patient and the situation, I'll do a combination of those things. And a lot of times it can help point you in the right direction. In this patient, we got a formal ultrasound that showed his EF, which had been around 45% a year ago, was down to 15 to 20%. So unsure the time course over the year with which that reduction occurred, but definitely a lot lower than we expected. My bedside ultrasound, I got about 22%. So I was a little off, unfortunately.
Well, we'll do a round of applause for the close estimate and for our demonstration. Good job, guys. I love it. All right. So we have a patient now who I think we would all feel very comfortable saying when their blood pressure, when they went into shock and they had fevers and they had this infectious source, that there was clearly some septic element to this. But we also now see with our POCUS exam, which we should definitely do in a shock patient, that their EF is 15 to 20%. So everybody's mind is going to go to mixed shock or what's going on, what's sort of driving this. And so, John, I was hoping you could talk to me about how you approach floating a swan in these patients. This is the question that always comes up. I do swans, I do radar casts, I love them, but this is like the first question I always get. All of a sudden, EF is down, we're in shock. Do we need a swan? When should we put this in?
Yeah, I think that's a really hard and a really fun question, because anytime that any one of our fellows or attendings even mentions a Swan-Ganz catheter in the ICU, like 5 fellows just kind of appear ready to go. But I think that it's also hard because, all my experience as an ICU doctor has been when I graduated in 2020 or after. So all of my critical care experience has been in a time when PA catheters have kind of fallen out of favor in the critical care setting. And there was a couple of trials, the Pac-Man trial and the ESCAPE trial in the mid-2000s, that showed no mortality benefit, maybe some complications associated with those. And so I have always grown up with attendings who are, I think, a little bit hesitant to place PA catheters in our critically ill patients. And I think it's, also a little bit different because, as Matt ably demonstrated, I think a lot of our fellows and attendings are very comfortable with POCUS and very comfortable with making a diagnosis of what kind of shock is happening with a POCUS exam. So I think most of us, when presented with a patient with undifferentiated shock, are reaching for the ultrasound and are calculating VTIs, calculating cardiac outputs, doing ultrasound-guided assessment of their IVC and of their neck veins, rather than reaching for a MAC and putting a MAC and a swan in. So to kind of rephrase your question, it's, when are we leaning on a PA catheter or a Swan-Ganz catheter instead of point-of-care ultrasound? And the best answer that I have to that is, 1, when I'm really confused about what kind of shock they have, or 2, when I really want to very thoughtfully and very carefully track our response to interventions that we're doing for their shock. Because I think all of our ultrasound tools are great at getting at a diagnosis, but tracking the response, tracking their cardiac output changes, the way their systemic vascular resistance changes in response to what we're doing with our vasoactive medicines, is quite hard with ultrasound and introduces some inter-rater reliability. So as we're signing out and handing off to our colleagues, it's really nice to kind of have this more objective, hopefully more universal source of truth that we can all use to kind of tell the same story and guide treatment in the same way for our patients.
I totally agree with that approach. I think it's like a super interesting question that's coming up now. As you mentioned, there's a bunch of trials that show that in advanced heart failure, that swans are not helping our patients, maybe even sometimes hurting them, because actually trying to diurese to normal sometimes is not good for our heart failure patients. And we have a bunch of data that in pure sepsis, we don't really need swans to drive this, and we're just increasing our complication rate. I think there's some interesting stuff now about cardiogenic shock, and especially in the world of MCS and getting to like early MCS devices, if swans can be useful. But that's honestly often in a different population than our general ICU. Certainly, like when we're doing more work in our cardiac ICU, then we have a different approach to it. But when I'm confused and I'm not sure what's going on, or when someone's in this true mixed state where I'm actually going to have to go back and forth between how much fluid am I giving or removing, am I going to be adding inotropes or am I going to be adding vasopressors, and I have to track it closely. And just as you said, that's when I start to think that this might be a helpful tool. So my understanding is that because this patient was a little confusing with this really low EF, and then the shock that was evolving and they were getting sicker, that a PA catheter was placed. So could you tell us what you guys ended up finding?
Yeah, so we did get a PA catheter in this patient. His initial numbers were shot on dobutamine and high dose, like in the 20s of norepinephrine. They were notable for a central venous pressure of 3. His mean PA pressure was 13, with a pulmonary artery occlusion pressure of 9, which my attendings tell me is the new, correct, and fancy and smart way to say pulmonary capillary wedge pressure.
I like it.
In on that. We calculated a cardiac index of 2.8 with an SVRI of 1925 for him.
Thanks so much, John. I think important to say, what agents was the patient on when you got these numbers. So saying that you were on dobutamine as well as high dose norepinephrine are going to be really important. The rest, I heard a lot of numbers. So Tim and I, it's too complex already for us. So Burf, I think we're going to have to go to you. I know you're a swan lover. So hoping you can walk us through these numbers and what the implications are.
I know neither of you guys need me for this, but I'll take it. That's fine. So, the nice thing about this is that it gives you like a really clear picture of what's going on. Obviously, you can always ask the question, fine, they're on dobutamine, they're on pressor. So like, would this change things? And it factors into my thinking. But this patient has a CVP of 3. They have a pulmonary artery occlusion pressure of 9 or a pulmonary capillary wedge pressure of 9. This patient is not in advanced heart failure, cardiogenic shock, right? Like if your heart is leading to that empty of filling pressures going on with this, then you're doing a very good job. Now we know that with a cardiac index of 2.8, and that's despite our SVR of 1925. And so this is the heart is pushing out very well. It's actually getting quite a good cardiac index against an afterload. The one thing that's always interesting in this is that someone could look and say like, well, I was taught that sepsis is a low SVR state. So this patient's SVR index is, like in the normal or getting up to higher range. And so, or in high range. So are they not septic? But I think we can be pretty clear that the heart is pumping out effectively. The pressures are low. In fact, this person is probably under resuscitated, right? And that their CVP probably should be higher than 3. Their wedge in a 6 state like this, we probably should be higher than 9, and output would go up. And the SVR is probably our pressors that we're giving, right? So we have just leave-fed on board that's creating this. And so this is just a great example, I feel like, of a person that just because you have a low EF doesn't mean you don't need fluid sometimes, right? So if this patient has a known heart failure patient with an EF of 15 to 20% and came in rip-roaring sepsis, we might have to resuscitate them. And we feel better about it with the SWAN now, but we certainly have all done that for patients who just need a little bit of fluid, and we can't be afraid of that sometimes. John, how did you guys end up interpreting and using these numbers? How wrong am I? Yeah.
No, we reached pretty much the same conclusion you did, and I remember this day on rounds really clearly because I had, Tim was actually my attending. I wanted to impress the PCCM program director here, and I thought that there was going to be like this extraordinarily complex physiology, and I was going to have all these kind of fancy convoluted plans for how we were going to strategize our vasoactive agents. And we ended up just saying, I think this is all distributive shock. I think we can manage this like regular, typical septic shock. So we ended up taking the dobutamine off, favoring norepinephrine and vasopressin. I think we did give him some volume back. And we kept the SWAN in for probably close to 72 hours, and his numbers never really changed from being very classically consistent with distributive shock. So it was at that point that we discontinued the PA catheter.
Thanks, John. And I'm sure that Tim had his notebook of physiology topics that he learned during fellowship. I feel like he still has that book with him. I could be wrong, Tim, but
I brought it. No, it's in my office.
Oh, yeah.
Yeah, I'm sure it is. Yeah, but
Definitely.
thank you, John, for walking us kind of through that. And I think you brought up a couple of great points here too. Like one, it's not everything has to be complex, right? You're like, okay, this is distributive. The PA catheter supported our decision. We're managing him correctly, and now what time is it to actually remove the catheter if it's no longer indicated? So I think walking us through that is really helpful. And it seems like overall, things are starting to trend in the right direction for this patient. He's on treatment for his PJP. Seems like respiratory status is improving, primarily distributive shock, resuscitating with some additional fluids. But Matt, how did things go after that? Tell us a little bit more about our patient's case.
So, the road to improvement is never straight. The
Mm-hmm.
patient had their ups and downs. They unfortunately developed renal failure, were on renal replacement therapy for a while, but did have renal recovery, was able to be extubated, and actually discharged to rehab and is doing fairly well. So, ended up being a fairly positive case.
That's awesome. I'm glad to hear it. Well, it's an amazing case. It was great to get to talk through some really core pulmonary critical care physiology and topics with you all. And we love every time we get to have a new program on our Fellows Case File series. So thank you guys for coming on. We're excited that we can welcome UVA to the Pulm Peeps family. We get some more episodes, I'm sure. But we always like to leave a little time for you guys to highlight what you love about the fellowship and the program there. So Matt, maybe we'll start with you.
And don't let the fact that I'm sitting next to the program director influence this endorsement anyway. I would
we
say
can see if there's any undue influence.
No, I'm a second year fellow here, and I'm just wrapping up my second year, and I've just really loved my experience here at UVA. I think there's so many positive qualities. There's a great leadership group. There's a great culture. But the one thing I'll highlight is just the nature of the schedule and the needs that we serve allows for a really unique and tailored fellowship experience. We get 49 weeks of elective or research time throughout our 3 years. And so it gives you time to explore all your research interests, like my research in sarcoidosis, but then do all the side projects that you want to do, like quality improvement work in the clinic, community outreach work we've been doing. And it also allows, too, for those of us who go on paternity leave, like I am right now, to easily work ourselves out of the schedule and have others ready to fill in those needs. So I think, as Tim's going to go into in a bit, there's a lot of great things about the program and the schedule that make this program really unique.
Yeah. Hey, congratulations. That's awesome. Yeah. I'm sorry that we brought you into work on your paternity leave. John, how about yourself?
Yeah. Would definitely second everything that Matt said, including the fact that I think I can hear a child outside the door. I think the other thing that I would highlight is how much I think our program, our leadership, and our fellows really embrace a very positive growth mindset. And every time I come on with a new faculty member, they're asking me what I want to work on and helping me get there. But also our fellows really help each other learn and help each other share in enthusiasms. I pretty much can't think of a day that goes by where one of my co-fellows does not burst into the workroom with great enthusiasm to sometimes rant for a long period of time, but sometimes briefly to teach about something that they have just been reading and learning about. So I feel like I have the faculty support helping me to be better, learn better, be a better clinician, researcher, teacher. But I also have my co-fellows helping me do that and being really positive role models, which is something that makes it really fun to get out of bed every day.
Yeah, it's awesome. Sounds like a fun place to work. Tim, how'd you build such a great program?
It's the fellows.
Yeah.
We like to describe ourselves as a Goldilocks program. We're not the biggest program. We're a medium-sized program. UVA Hospital is not a very large hospital. It's also not a small, so it's a medium-sized hospital. So we kind of find that sweet spot. We also, I think, emphasize pulmonary equally with critical care. So we're not heavy on one of the specialties versus the other. And at the end of the day, our primary goal is to train clinicians to be outstanding at their job and to be able to practice to the absolute peak of what they should be expected to do when they're out there alone in the community. And so we don't subcontract really anything that we think our doctors should be doing to other specialists. So our fellows leave here prepared to be a complete pulmonary critical care doctor. And at the same time, they get to have freedom in their schedule to to really develop a bespoke fellowship where they get to be the doctor they want to be. And we collaborate in a way that it's their program. If they have ideas, then we run that up the flagpole and see if the other people will salute it. So that's our program in a nutshell.
That's great.
Well said.
Yeah. Such an
I will
awesome
also
program.
add, it's fun to be a program director and to work with other program directors in the country, like Christina. And probably my favorite conference is going with the program directors and learning new ideas, and have really enjoyed that part of being a program director.
Yeah, well, couldn't agree more, Tim. I was like, I know, it's like APCCMPD is like some of the nicest people in the country, just like in the same room, always, wanting to do more for medical education and pulmonary critical care medicine. So, such a fun conference, and always enjoy seeing you there. And really, I think, a fantastic program. Obviously, today, the collegiality is transparent, and I know that this is what happens day in and day out at your program. So anyone listening today, applying into pulmonary critical care this application cycle, make sure you check out UVA, get to meet John and Matt, and get to meet Tim and ask him about the Scialla protocol going forward. But really, a great case that we went through today, and I think something that people will see throughout their career, and definitely a consult as a fellow and a patient that many of our trainees are probably caring for. I think as we like to end with a teaching point, and Matt, I was going to go back up to yours. I really just liked you kind of walking us through the difference between, PJP testing, the DFA, as well as the PCR, and the difference between those two. So that was my teaching point for the day. But Furf, I'd love to hear from you.
The thing I'm gonna take from today and put in my vernacular is Tim's rotation versus revolution. I like thinking about a patient, and again, it's a gestalt when you see someone, but it is like the question in your mind is like, are we going to turn this around really quickly, or is this going to be a while? And if it's going to be a while, that's going to change my approach.
Absolutely. Tim, what about you?
I'm just so darn impressed with the fellows. They took all the initiative here to meet you guys, and Matt and John coming up with this script and roping me into it. Really impressed with our fellows.
We're impressed too.
Awesome. Matt, anything you want to share as far as a teaching point from the case today?
For me, this is definitely going to influence my bronchoscopy consenting in patients like this. We all know that there's benefit and there's risk, but now being able to put numbers to it that 40 to 60% of the time in these kinds of patients, it changes management, but 10 to 15% of the time, it leads to complications with significant outcomes. So it doesn't necessarily change what I do, but it makes me more educated in how I do it.
Yeah, great perspective to carry forward. And John, what about you?
One of the things that this case taught me that I really try to carry forward is having a lot of humility in approaching either new or worsening shock in a patient. And I try really hard not to anchor on what the etiology to their shock is, but rather come in with a broad differential, do a thoughtful physical exam, do a thoughtful point of care ultrasound exam, and reach a conclusion based on all that data. I mean, we know that most patients are going to have distributive shock, but the management varies a lot depending on that first diagnosis, and it's a high stakes game to play. So I try to be very open as I'm meeting those folks.
That's great. Well, thank you guys again for coming on. This was a great episode. Thank you all for tuning in and listening. This episode was produced and edited by myself and Christina Montemayor, and the music's original music by Eric Rogers. And we'll see you next time.